Assalamu alaikum. Good morning, good evening to all of you. Sharif, can you hear me?
Yes, we can hear you.
Yes,
All
we
right.
can hear you.
All right, perfect. So Assalamu alaikum. My name is Ahsan and I'm Surgical Neuro-Oncology Fellow at the Khan University Hospital. On behalf of Pakistan Society of Neuro-Oncology, PASNO, I welcome you all to our webinar series. PASNO is organizing Neuro-Oncology webinar series, and each webinar in this series will be an hour long, and it will be held on alternate Saturdays. There is no fee for the participation, and the certificate of attendance will be given to all the attendees. To make these sessions more interactive, we have divided them in two halves. First 30 minutes for topic presentation, and then there will be an open discussion with the speaker by Dr. Rashid Juma, Dr. Atharinam, and the attendees. All the participants will be muted during the session so that the speaker can present without any interruption. Questions can be submitted in the chat box and will be answered once the presenter has finished his talk. Participants can also raise their hands for questions. We will unmute them to speak. The sessions will be recorded and the link will be shared on PASNO's official website. So today, the topic of our webinar is insular gliomas, current concepts and surgical nuances. And we are really honored to have Dr. Muhammad Omar Chohan as our first speaker in this webinar series. Dr. Muhammad Omar Chohan graduated from Khan University, Pakistan in 2002. He spent the next 5 years at the New York State Institute for Basic Research, and he was awarded World Association of Alzheimer's Disease Scientists Award in 2005 for his work on small molecule development to enhance neurogenesis. Dr. Chohan started neurosurgery residency at University of New Mexico in 2008 and graduated with the Best Resident Leadership Award. He finished his fellowship training in neurosurgical oncology at Memorial Sloan Kettering Cancer Center, Weill Cornell Medical College in New York in 2015, and returned to his home institute, University of Mexico, to build neuro-oncology program as assistant professor in 2015. At University of New Mexico, he was the director of neurosurgical oncology from 2015 to 2020, and director of epilepsy program from 2019 to 2020. Dr. Chohan is presently working as associate professor of neurosurgery, neurology, and radiation oncology at University of Mississippi Medical Center in USA. Without further delay, sir, I would invite Dr. Muhammad Omar Chohan to present his talk. Over to you, sir.
Assalamu alaikum. Thank you for having me here, Dr. Nam, Dr. Juma, and Ahsan, the organizing committee of PASNO and the Neuro-Oncology webinar series. I'm really honored to be able to talk to you about something that interests me. I am a proud graduate of Khan University, so anytime I get a chance to reconnect to my roots, I just grab it right away. So let's talk about these very difficult tumors. Insular gliomas have been talked about, written about for decades. These are very difficult tumors, and the more we learn about the physiology of insula and the surrounding structures, the more insight we get into better ways of approaching these tumors and eventually to have a better functional outcome for our patients. This is my contact. I'll leave my contact at the end of the talk as well for those of you who want to connect with me. I don't have any relevant conflicts of interest for this talk. I'll start with a case, as everybody does, and then we'll come back to this case at the end of the talk to see what we have learned so far. So this is a 32-year-old young male that I saw a few years ago with first onset seizure. He was neurologically intact from a neurosurgical standpoint. take that with a grain of salt. And this is his MRI, which is a FLAIR image. You can see on the left side of the screen here. There is a FLAIR hyperintense expansile lesion, which is deep in the brain. It involves anterior part of the insula and then goes into the orbitofrontal lobe. And the corresponding sagittal and parasagittal images confirm that. So this is an insular glioma that this kid had. Insula is hidden deep in the brain. It is covered by the opercular surfaces of frontal lobe, temporal lobe, and parietal lobes. The function of insula is still not very well understood. There are a lot of functional MRI studies coming out now that are adding to the role of insula. There's no one specific physiological function that the insula does. It is considered to be a hub of integration of motor and sensory inputs. There are some studies that also suggest that this is that insula is responsible for visceral awareness. The awareness that we have internal organs is modulated by insula. Quite interestingly, it is also involved in what we call phoneme recognition. So recognition of novel sounds. How do we recognize what we are hearing is novel versus familiar? And by that, it is involved in acquisition of new languages, foreign languages. And so insula is has a lot of new functions being ascribed to it. It is very close to auditory input from the temporal lobe, very close to language inputs from the opercular surfaces of the frontal lobe. So in addition to vestibular sensory integration, it is not surprising that it is involved in language as well. So very, very important structure to keep in mind. Consequently, tumors that arise in the insula are unique. Insula hosts more low-grade gliomas than high-grade gliomas. About 25% to 1/4 of all low-grade gliomas are originating at some point in the insula, as opposed to 10% of high-grade gliomas. Obviously, there is a clear propensity of low-grade histology, and even within the low-grade glioma umbrella, low-grade insular tumors are even more slowly progressive and have a very prolonged clinical course. Patients are, when they present with insular gliomas, are almost always neurologically intact. They will often have a seizure, and the seizure is often the first symptom. It may be your classical insular epilepsy. And so insular epilepsy has a very particular semiology. Usually occurs, most of these seizures are usually nocturnal seizures. They'll wake you up, and when the patients wake up, they often describe themselves as being able to feel their internal organs, like spleen or liver, and they will clutch their throat because they can feel their stomach coming up to the throat. So this visceral awareness is very much emerges in insular epilepsy, and that is often the first symptom of these tumors. Also, as opposed to cortical or surface low-grade gliomas, insular gliomas, most of the time, not always, they will grow within the phylogenetic zones. What that means is they tend to respect the medial structure. So deep underneath the insula, you have your basal ganglia and internal capsule. Majority of the tumors will not cross that boundary. And so when you look at, and we'll see some of the images coming up that will highlight this point. Also, as discussed before, patients with insular gliomas have a higher progression-free survival, and some people would argue overall survival as well, but that depends on how they are handled surgically compared to cortical low-grade gliomas. So then the key questions for a neurosurgeon is, we know that maximum safe resection does provide survival benefit in cortical low-grade gliomas. Can we say the same about insular gliomas? So that's the first question. Another question is, does location or organization within the insula predict how much tumor a surgeon is able to take out? And what is the perioperative morbidity in doing so? And quite related and equally important third question is immediate postoperative functional decline real? And is it then prohibitive for neurosurgeons to offer resection? A key point here is that the incidence of immediate postoperative deficits is very, very high in insular glioma patients. But that does not pan out at 3 months if the surgery is done using certain principles and carefully. So the basic principles for all low-grade gliomas is that they will all grow. We know that. Natural history dictates that they will all eventually transform from a low grade to an anaplastic and then grade 4. And therefore, maximum surgical resection should be the first line of treatment for insular gliomas. They are no different than cortical gliomas. And by the same token, extent of resection will affect progression-free survival, overall survival, and malignant progression-free survival in these tumors as well. I like to show this graph a lot. This is one of my favorite graphs in neuro-oncology. What it shows is that for a neurosurgeon, we are mostly concerned about the x-axis. So you can put anything on the x-axis: time to malignant transformation when it comes to a low-grade glioma, or time to recurrence when it comes to a high-grade glioma. So we want to maximize oncological benefit. What we often fail to recognize is the functional price that patients have to pay for it. So we always want to be at number 4 right here, that we are not compromising time with quality of life or functional functional output of the patients for an oncological benefit. So you never sacrifice functional benefit for oncological benefit. I think that's a very important point here. Because if you maximize oncological benefit and the person is functionally not able to return back to society, then I don't know what you really have done for the patient. Delaying surgery, I think this is just a reminder of how low-grade gliomas grow. We are all familiar with the radiological birth. And backtracking, nobody knows what the biological birth timeline would be. But now we know that from the time a tumor is diagnosed on an MRI or on an imaging study, even if the patient is not symptomatic, there is a lead time, and that lead time is about 15 years. So if you are waiting on a patient with a low-grade glioma to become symptomatic before you act on it, then you are allowing all of these things to happen. Malignant degeneration, neurological deficits, if the patient has, to become permanent. A seizure disorder would become more resistant to treatment. And so on and so forth. So I think my philosophy and a lot of neurosurgical oncologists, their philosophy is to treat the patients, even an asymptomatic patient, because we know that the lead time can vary up to 15 years, and that is a lot of time to allow a tumor to sit and accumulate mutations. So let's switch gears to insular gliomas now. Like everything in neurosurgery, insular glioma literature started with Dr. Yazergil. He is the father of modern neurosurgery. He presented the first large series on insular gliomas ever written in '92. He came up with a classification scheme for insular gliomas. His patients presented were 35. That was the largest series. Since then, a few more series have come around. There are smaller series as well. Dufau from France in 2009, he presented 51 patients. And then the famous paper that we'll talk about in 2010 from Mitch Berger's group had over 100 patients. And they came up with a very nice way to surgically think about insular gliomas. More recently, there have been two papers from China that have looked at a particular technique in approaching insular gliomas, and they had over 200 patients. So if we quickly go through the 2010 Mitch Berger paper with 104 patients, the punchline was that these patients are, their mean age is always very young. They are often less than 40 years of age. The punchline was that an extent of resection of greater than 90% provided the most benefit. So that turns out to be a volumetric threshold that predicts a better overall survival for these patients. So if you look at this graph, this Kaplan-Meier curve on grade 2 gliomas, on the top you have greater than 90% resection, and their timeline, they still haven't met their overall survival. So currently, the overall survival for the best type of low-grade glioma, which is a molecular oligodendroglioma, stands at 15 years. That's median overall survival. And I would probably think that insular gliomas, if they are resected more than 90% of their volume, would probably parallel that of a cortical glioma. And that also held true for anaplastic gliomas, although their overall survival is not as good as grade 2 gliomas, but you can see a very clear demarcation between a volumetric resection of 90% or less. And then progression-free survival. I don't like progression-free survival because it never correlates with overall survival, but people still talk about progression-free survival, and that's a philosophical issue that we can talk on the sidelines. Malignant progression-free survival is very important. So how long does it take for a low-grade glioma, grade 2 glioma, to transform into a high-grade glioma, grade 3 or grade 4? So again, extent of resection positively influences malignant progression-free survival as well. So in summary, the extent of resection follows the same general glioma principles, just like the natural history. We learned that the more you take out, the better it is for the patient, not at the expense of function, though. And turns out that 90% is where that sweet spot is. 5-year malignant progression-free survival is increased by almost 20% with a resection that is more than 90%. And then, several other studies, it was started with this, but several other studies have also recommended a resection or re-resection of recurrent tumors. Although in the insula, that can be particularly challenging for the neurosurgeon. Going on to how various surgeons have looked at these tumors. So Yazergil obviously came up with the first classification of insular gliomas, and since then there have been several iterations of insular gliomas in terms of their surgical orientation, surgical approach, how to think about these tumors. And some of these, as you'll see, I'll go through some of these briefly. You'll see that they all are similar in one way or the other. So starting with Dr. Yazergil, we don't use this classification anymore. At least I don't use this, but it's very nice to actually put the insula within the broader context of tumors within the limbic and paralimbic systems. So this is the insula, and its proximity to, for example, the hippocampus and the amygdala and the orbitofrontal lobe, binds it together within a circuit of the limbic and paralimbic systems. So for Yazergil, he called these tumors as either type 3A, type 3B, 5A, and 5B. The differences being that 3A are tumors that are solely in the insula. They haven't spilled out into the cortical surface. 3B is when they start to involve the opercular surface of either the frontal lobe, parietal lobe, or the temporal lobe. And then 5A and 5B are more extensive tumors where, for example, in 5A, the tumor has spilled into the orbitofrontal lobe or the temporal pole, and type 5B is when they are giant tumors that involve the mesial temporal structures, including amygdala and hippocampus. Pat Kelly came up with this vascular thinking of insular gliomas. What he suggested was that if you do an angiogram on these tumors, and if you see that the lenticular striate artery, which by the way does not feed the insula, if it's medial versus within the tumor, then it dictates how much tumor you can remove. So the thing is, if you are removing an insular tumor, and the moment you start seeing the moment you start seeing lenticular striate arteries, that's the time to stop. So tumors that have lenticular striate arteries involved, they don't lend themselves to a complete resection or a better resection. And these are the tumors where you have to be very careful about postoperative deficits and going slowly and really understanding your approach. A very similar way of describing insular gliomas is this putaminal involvement. So most insular gliomas will respect the medial boundary, as we talked about early. So this is your basal ganglia boundary to an insular glioma. There's a very sharp demarcation in most of the tumors. But if there isn't, like this, and I would submit that these are the tumors which will have lenticular striate arteries involved within the tumor, then this is another way of thinking about it, that these tumors will not lend themselves to a better resection. And tumors that involve the putamen will have a higher risk of postoperative permanent deficits and a lower extent of resection. So this is important for neurosurgeons to look at and discuss with the patients when we see somebody with that insular tumor. Surgical approaches to the insula, they have, so basically there are two standard approaches to approach these tumors. Either you open the Sylvian fissure or a trans-Sylvian approach that was popularized by Dr. Yazergil, or you go through the cortical surfaces of the opercula, the frontal and temporal opercula, which is called a transcortical or transopercular approach. And then depending on how large the tumor there is, you may have to do an anterior temporal lobectomy. And one might think, what would be the order of approach? Should you go after the insular tumor first, or should you do temporal lobectomy first? Should the patients be awake during these surgeries? Should you do an asleep-awake approach? And so these are some of the surgical nuances that the surgeon will have to deal with when thinking about these tumors. And no two insular gliomas are the same. So tumors which are just in the insula, obviously they don't require an anterior temporal lobectomy. In my own hands, I have dealt with these tumors both ways, transsylvian and transcortical. Again, in my hands, I tend to prefer the transopercular approach, and we can have a discussion at the end of the talk. What you guys do, what Dr. Anam and Dr. Juma think about these approaches. But I think the bottom line is these tumors are rare. Pick an approach and stick to it. Perfect that approach, and the patients will have a better outcome. They're proponents of both approaches. I do all these patients awake, whether we are dealing with dominant hemisphere tumors or non-dominant tumors, and we can talk about that as well. I know some of my colleagues will do non-dominant tumors asleep, and that's fine as well. Whatever works in your hands, whatever makes the most sense, and whatever gives you the best outcome is the approach to go by, as long as it conforms to certain surgical principles. So I think it's important to understand the anatomy of insula, which can be complex. We talked a little bit about the opercular surfaces, frontal, parietal, and temporal lobes. It is equally important to understand the relationship of internal carotid artery, MCA, and lenticular striate arteries as you are going deeper in your approach. So just going through some pictures of a cadaver brain. So this is the opercular. This is the frontal operculum, temporal operculum, parietal operculum. Here, when you are considering a transcortical approach, obviously the sylvian fissure is not opened. If you're doing a transsylvian approach, the sylvian fissure is opened as soon as you retract the opercular surfaces, through a transsylvian approach, the insula emerges. Obviously, in real life, you can never open, or you should never try to open the sylvian fissure and retract it the way it's shown here. And that is one of the problems with the transsylvian approach that we'll talk about a little bit later. But that's the extent of the insula that can be exposed with a transsylvian approach in a cadaver, not in a live human. So that's something to think about. So as you start going through the opercular surface, you can see how the insula is organized in an anterior to posterior fashion. You have the three short gyri, the anterior, middle, and short gyrus of the insula, separated by the central insular sulcus that separates the anterior short gyri from posterior long gyri. This central insular sulcus is continuous with the central sulcus proper on the cortical surface. And that's where the long insular artery also lies, which is the most important artery to save during insular glioma surgery. And as you start going deeper, you are approaching the no-go zones of basal ganglia and the internal capsule. Now, I have my mentors when I was in fellowship. They often talked about, and I'm sure you guys have heard about, this nutmeg appearance of basal ganglia. To be honest, I have never seen nutmeg appearance of basal ganglia. I don't look for it. I think people who have done hundreds and hundreds of these gliomas may be able to differentiate or have a better understanding of when anatomically you are up against the lentiform nucleus or the basal ganglia. But for me, I rely heavily on tractography and subcortical mapping, and so that's my safety zone. I'm not looking for the nutmeg appearance. Vascularity, very briefly, you first identify M1 at the Lehman insula. where it's bifurcating into M2. There are up to 96 insular arteries. Most of them can be taken with impunity, but the long insular artery is the one that you have to be very careful about, because that's the one that irrigates the internal capsule and can cause permanent significant neurological deficits. And so there's a concept of candelabra, or creating windows between bigger insular arteries, because you can take small insular arteries, but anything that appears bigger, like an M2 caliber, you should consider those important arteries and just work between those arteries by creating windows. So let's look at that. So here's your Lehman insula, and the MCA is bifurcating right here. The long insular artery will run in the central sulcus of the insula. So right here, this is the long insular artery that runs in the central sulcus between the anterior and posterior portion of the insula. And that's how you work. You create these windows between the arteries. I'm a heavy user of intraoperative papaverine, so I will always have gel foam soaked in papaverine, and I lay papaverine on these insular arteries as I'm going through. These are long and tedious surgeries, and the arteries can undergo vasospasm, especially you're working under the heat of the microscope, and the atmosphere is dry. So you want to make sure that these arteries are always irrigated. They have some papaverine on it, and you are paying attention to this. Because at the end of the day, if you end up with a good oncological outcome, but an artery that underwent spasm and caused a stroke, then nobody's happy. This is an intraoperative picture of how these windows are created. This is obviously a transcortical approach that you are seeing here. So going back to the surgical zones, this was a very good way, a very useful concept that came out in 2010, Mitch Berger's paper, that basically divides the insula into 4 corridors or 4 zones. And that is based on the orientation of the Sylvian fissure, a line that parallels the Sylvian fissure, and another line that crosses it based on the foramen of Monroe, ipsilateral to the tumor. And so you have 4 zones, 1, 2, 3, and 4. The tumors are not organized as neatly. So a majority of the tumor would be in one of these zones. And if it involves all 4 zones, then it is considered a giant tumor. Another way of looking at these zones, and if we now put together a surgical framework, so in order for you to approach a tumor in zone number 1, which is the anterior superior zone, you'll have to go through the opercular surface, including pars opercularis and pars triangularis. And so that's where in most patients, the receptive or the expressive node of language is on the dominant hemisphere. So bear in mind, in a transcortical or transopercular approach to zone 1 tumors, these patients have to be awake, and you have to make sure that you're not going through Broca's area. Then zone 2, which is the posterior superior zone, you have to go through precentral gyrus, which is the motor strip. The lateral most part of the motor strip is face representation, and it is forgiving because face has bilateral representation. But obviously, again, careful, meticulous mapping is very important. Zone 3, which is the lower zone, posterior inferior zone, you have to go through the posterior part of the superior temporal gyrus, where the auditory network is. Again, auditory network is bilateral, so it is forgiving. However, this is also the area where the receptive node of language, or Wernicke's, as it used to be called previously, often is. So again, the importance of meticulous mapping has to be borne in mind. And then the easiest one is the final zone. And so the picture that I showed you at the beginning, laying out the insula, these are the various zones superimposed on them. So there have been analysis on the comparison between a transcortical approach versus trans-Sylvian approach. I think the bottom line is both approaches are quite comparable in a surgeon's ability to remove the tumor, except for when the tumors are in the superior posterior zone, where so superior posterior zone is directly under the parietal operculum. So the angular gyrus, the posterior bank of frontal parietal operculum. And in a trans-Sylvian approach, you can never open the Sylvian fissure so wide that you are able to access that area. So in a trans-Sylvian approach, that is what we call the surgical blind spot. Now in transcortical approach, if that opercular surface is eloquent, you obviously cannot go through it. But if it is not eloquent, then you go through it and remove the tumor in that area as well. So it depends on what approach you are taking, and it depends on presence or absence of eloquent tissue in that area. I will skip these two papers that these were the two more recent papers from China, that 200 plus patients that basically talked about transcortical approach only, and they confirmed earlier findings of greater than 90% resection predicts overall survival for both high-grade and low-grade gliomas. I'll just very briefly talk about my personal experience, and then we'll go back to the case that we opened up. Insular gliomas, these are all my cases, so they can just remain within the insula, as you see on the left side. They can have frontal extension into the orbitofrontal lobe. They can have temporal extension. When it comes to eloquence, we need to understand the functional boundaries. I think we have been talking about that all along. Equally important are the tracks involved. What are the tracks? What are the white matter pathways that are involved in the insula and in the neighborhood of the insula? It's very, very important to have a good DTI reconstruction of the region and understand what you will be going through. So functional boundaries, for example, this tumor, again, a young patient with insular involvement and frontal involvement on the dominant hemisphere. And you can see that, you know, the expressive node of language is right there. It's right there. It's the purple one. And this and the red is the face. And so, you know, as we all know, our brains are not color coded. And so it's important to have in your mind an organization of function surrounding the tumor. Temporal extension. Now, this is a non-dominant hemisphere, a right-sided hemisphere, but this patient who's a female. So again, it's important to, you know, that's the reason that one of the reasons that I like to do these patients even on the right side while they're awake. This lady had language dominance on the right side, so you can see the expressive node is right here on the right side. Yellow is auditory. It's fairly forgiving, and you can see on the sagittal view how these very eloquent areas are just surrounding the tumor. These tumors follow pathways, fiber tracts. So, for example, this giant frontal insular tumor, you can see at the bottom here, is probably going through the uncinate fasciculus into the temporal lobe. And you can see the eloquence of the tissue surrounding the tumor. This giant tumor, again, on the non-dominant side, you can see how the area of uncinate fasciculus is expansile or has expanded. And it involves right over here at the bottom axial scan. It involves the hippocampus, part of the hippocampus, and amygdala. So this tumor would be classified as a Yazergill type 5B, or a giant frontal insular temporal glioma. And it is these kind of tumors where you have to think about what should you do first. Should you remove the temporal lobe, which is my preference, because that allows you more working space in the insula. Pathways, very briefly, I know we are running out of time, I think. So pathways that are involved, obviously your corticospinal tract, superior longitudinal fasciculus, arcuate fasciculus, uncinate fasciculus, IFOF, and frontal ascending tract. Not only knowing what these tracts do, where they are located, but also equally important is how do you test these intraoperatively? How do you do subcortical mapping to know where these tumors are? Vascular surgeons will tell you that they rely on the lenticular striate arteries in a trans-Sylvian approach, where you have exposed M2 and you're following that over the Lehman insula. I rely on that as well, but I rely very heavily on the presence of IFOF, because for me, IFOF is the medial most boundary of your resection. You cannot traverse IFOF. If you traverse IFOF, then you are in the anterior perforated substance, where these small lenticular striate arteries are going through, and the game is already over. So I rely heavily. The deeper you go, I think the tracts are not affected by brain shift that much, and you can subcortically reliably test those tracts, some of those tracts as well. Non-dominant hemisphere, there's just a few notes that non-dominant hemisphere, there's a lot of talk, there's a lot of understanding within the neurosurgical community of the importance of the non-dominant hemisphere, which is involved in a lot of what makes us human. Social cognition, knowing that I have my beliefs and you have your beliefs, something that's called theory of mind and mentalization. And so a lot of these concepts, which were very well known in the neuropsychology community, are now bleeding into neurosurgical community, and a lot of neurosurgeons are taking these into consideration, and hence doing more of these tumors even on the non-dominant hemisphere, which I think is a misnomer from what we know, that the right-sided hemisphere is not non-dominant. It has all of these very, very important functions. So, you know, this tumor, for example, is a frontal temporal insular tumor. You can see the arcuate fasciculus. You can see IFOF that connects the orbitofrontal lobe to the through the uncinate fasciculus to the temporal lobe, and also goes back and feeds into the occipital lobe. This is the uncinate fasciculus here. This is another case of dominant giant insular glioma that again highlights these key areas. This is what would be considered the surgical blind spot, because you can't open the Sylvian fissure all the way back to here, and to get through it through a transcortical approach, you have to go through probably some eloquent tissue. If it's not there, then you can do it. If it's there, then obviously this tumor would be left behind. Again, how the functional shows surrounding eloquence in the brain tissue. So to wrap up, let's come back to the case illustration. So this 32-year-old male with a frontal insular glioma. These pictures that we saw earlier, the tumor is involving the anterior part of the insula, we know, and it's spilling into the orbitofrontal lobe. So the tracts, we already know what tracts are going to be involved. Here, you'll have involvement of the IFOF, obviously, because IFOF will start here. It will connect to the uncinate fasciculus in the mesial temporal lobe right here, and then go all the way back to the occipital lobe. And some of your language-associated pathways like superior longitudinal fasciculus and arcuate fasciculus. So the functional MRI showed language all around. This is the expressive node of language. So Broca's area, this is face, this is auditory, and back here is your receptive node of language, or Wernicke's. These are the pathways. This is IFOF going all the way back to the occipital lobe. This, again, I will emphasize, is your medial most boundary. Once you are at the IFOF, you cannot go further because you will be looking into the lenticular striate arteries and the anterior perforated substance. This is the arcuate fasciculus, and then putting everything together with the corticospinal tracts and all the various deep pathways on a sagittal and an axial view. Here you can see IFOF very nicely showing you the medial most boundary of your resection. Another way to look at it, again, different pathways that are involved around the tumor. Important to understand, important to respect them. And I did this through a transopercular or transcortical approach. You can see naming and expressive speech. Luckily for us, was at least a gyrus away. This tumor is also very, very anterior. And so I don't like to show videos, but this is one where I'm gonna mute. This is an intraoperative illustration of when we are when the tumor was resected. I'm just pointing out the extent of resection is quite good if the patient is awake, and we are right up to the internal capsule. We are right up to the corticospinal tracts here in this resection, and right down to the gyrus rectus and the orbitofrontal lobe. This patient ended up doing quite well. Complications, important to know. Long insular artery will do this. The patient will have permanent hemiplegia or dense hemiparesis. Important to understand that. And this is the surgical blind spot that we were talking about, this posterior part of the superior insula where you can't open the sylvian fissure wide enough to get to it. And so a transcortical approach is often taken. And I will leave you with this graph again, that as neurosurgeons, we want to be right here and hopefully not here, not down here. Papers worth reading. I think these two papers are very nice. The first paper is from Dr. Roten. Everybody knows him, everybody respects him, respects his work, microsurgical anatomy. And then this is a thought paper that Dr. Berger wrote a couple years ago that summarizes the philosophy of insular glioma surgery, some of which we talked about. And this is my contact. And that's all I have to say.
Thank you very much, Dr. Chohan, for such an excellent presentation. Really,
thank you.
Really nice. So I would now request Dr. Juma for his comments. Dr. Rathar,
yeah,
would you like to add something? Yes, sir.
So while Dr. Juma is turning his mic on, can you ask the audience if they have any questions? They should
sure.
Start write it down in the chat box.
Right. So yeah, audience can write down the questions in the chat box, or they can also raise their hand if they want to talk, if they want to
Right.
ask by themselves. So,
Absolutely.
yes, you're welcome.
Dr. Juma, you're still mute. Do you want to say something, Dr. Juma? मेरे ख्याल में उनका वो नहीं हो रहा है. Okay, so I will
I think
proceed.
Dr.
So, yeah. So SM,
Sorry.
Dr. Juma, आपकी वो आवाज सही नहीं आ रही है.
Gentlemen, sorry about great talk. And I'm particularly at insular glioma surgery. And when I say advanced, it's because it brings into full play the DTI tractography, which is the kind of which is the new frontier guiding these resections. So really great work. And I mean, you know, we could argue and discuss the 2 or 3 options that you spoke about, you know, approach and but I think that it's really, as you said, it's what works best for you and what you're most comfortable with. That's important, which eventually goes back to what you've been trained in or what you've seen. So I think that, but I think that the really important thing which you brought out is you've got to know your anatomy and you've got to now have your DTI information available. Sir, was I audible in all that?
Yes, sir, you were, sir.
Yes, it
Excellent.
was.
Okay.
Great. Thank you for your
sir.
comment, Dr. Juma. So we have Talha Abbas. Talha, can you unmute you and ask a question yourself? Talha has some question about candelabra concept. Talha, are you there? Okay, so Umar, Talha Abbas, I don't know who Dr. Talha Abbas is. Oh, here it is. Talha, can you speak? You're unmuted, Talha.
So, Talha,
Okay, well,
yes.
there is, yes, Dr. Talha Abbas. आपकी आवाज नहीं आ रही, अनफॉर्चुनेटली आपकी आवाज नहीं आ रही है. You're unmuted, आपकी आवाज नहीं आ रही है. But we can repeat your question, Dr. Talha Abbas. The question is basically he wanted to find out if you can explain the candelabra concept again and 5-ALA for safe resection. That was his question.
Right. So candelabra means that you are basically creating windows. So as you know, the surface of the insula has the M2 and M3 vessels draped over it. So surface of insula has a lot of vessels, up to 96 vessels in some cadaveric studies. So the larger vessels, one of which would be the long insular artery, you obviously have to make sure that you are not injuring the vessels. So you work in between the vessels. So you identify 2 vessels, then you make a corticectomy and you start approaching the tumor in between vessels. So in this way, as you are progressing in your surgery, you are creating windows or candelabra with the vessels still in between your resection cavity. So that's candelabra. You're not allowed to take any large vessel in an insular glioma surgery. And your second question was the use of 5-ALA. I'm a big proponent of 5-ALA. I was regional PI of the trial that just concluded. We actually have a publication coming out, I think, in JNS this month on the FDA approval of 5-ALA in the United States and the trial that we did. Yes, absolutely. I use 5-ALA for all high-grade glioma cases. The problem with 5-ALA is it's very subjective. Although there are now handheld spectrophotometers to actually quantify the amount of protoporphyrin fluorescence in tumors, but those are not widespread, those are not practical. So the amount of fluorescence that your and my eyes can appreciate is the subjectivity inherent in 5-ALA. but it's a wonderful technique. It doesn't work for low-grade gliomas, at least as of now, but works in anaplastic and high-grade gliomas. Use it all the time.
Great.
Thank you.
Thank you. So we have any other question at this point? I have a couple of questions, Umar. So
Yes, sir.
number one, the Pat Kelly's concept about this ventricular striate arteries, and he recommended angiogram. I've never done those angiograms before.
Right.
So you done those angiograms before
No.
surgery? No.
No,
Okay.
I don't do them.
But then I think they were doing it in NYU on a regular basis, right?
That's correct. That's
yeah,
correct.
right.
Yeah.
But
Yeah,
it's
I don't
still-
think there's any need to do. I think at that time, at least that's what I would like to think. That at that time, tractography and subcortical mapping of these complex pathways like IFOF were not widespread.
Right.
And I think it's an important concept. It just brings home the same point, the importance of vascularity in this region. Everything is so close together. Again, I don't use angiograms for these resections at all. Have never done that.
So we
Sir,
have
Farhan
we
Mirza
have
has raised his
Oh.
hand.
Yeah.
Sorry.
So we have Farhan, your AQ alumnus also.
Absolutely, I know Farhan. Assalamu alaikum, Farhan. How are you?
Farhan Ansari
Walaikum salam.
is back from Canada after finishing his fellowship in epilepsy surgery.
Oh,
And
fantastic. That's
yes.
great.
Ji Farhan.
Yeah,
please.
thank you. This was really fantastic. It's great to see Dr. Atharanam and Dr. Juma and obviously Dr. Chohan. It's been a while since we met. I think it was 3 or 4 years ago. Yeah, when we met
At a
at
conference.
that brain mapping
Right.
course. Yeah.
That's right. That's
yeah.
right.
So I'm back at University of Kentucky. I got back last year. So I'm finishing my first year as faculty here. So it's been
beautiful.
quite fun. Yeah, doing epilepsy surgery and brain tumors. So kind
Very
of
nice.
following in your pathway and Dr. Atharanam's
That's
pathway.
beautiful.
Yeah. So really nice talk. And I've done a few insular gliomas thus far. What I've seen is as you get through that T1 hypo intense part, which is different, and
Right.
you know it's different.
Right.
You can see it's
Right.
different. You feel it's different. As you
Right.
get to that medial margin, that last 4 or 5 millimeters, which is immediately lateral to your basal ganglia, that starts looking normal or somewhat normal, and you lose that tactile haptic feel. How do you negotiate that? And my second question is, how do you test IFOF?
Right. So very important. Both questions are very important questions. So the first question is, how do I know that I am close to the basal ganglia? I think I keep the patients awake and I do subcortical mapping. Both of them help, and I use intraoperative DTI. I rely more on intraoperative DTI than functional MRI. We all know functional MRI is a hit or a miss. It's never accurate. It gives you, lay of the land, but you can never go by it. But DTI is very useful. I also am a heavy user of intraoperative ultrasound, so that helps as well. We do not have intraoperative MRI. Do you guys have it in Kentucky? IMRI?
No.
Okay. I think it's overrated, but whatever, a $5 million, $10 million investment. But I think if you're using all these different techniques, use your ultrasound. It's going to be your best friend. Invest in a good neurosurgical ultrasound and get good at it. And also using subcortical mapping, I think I have never transgressed into the basal ganglia. And at the beginning of the talk, I was mentioning how people say that you will know when you're close to the basal ganglia because it has this nutmeg appearance. I've never seen it, but again, I have not done 200 insular gliomas, so maybe it's my naivety.
Well, I have
the second question.
I've seen the nutmeg appearance, Umar, but I haven't done that many either. It's just that
Okay.
I think I go too far deep. That's the problem.
Yeah.
Right.
You are a
So
different surgeon.
We have another question, sir, from Dr. Saqib Bakshi. He's an instructor here at IKU
Saqib,
in Neurosurgery.
Yeah, Dr. Saqib can.
I'm sorry. Can I answer Farhan's second question?
Oh,
He
yes.
had a
Sure.
question about IFOF.
Sure.
How do you test IFOF? Debatable, very, very debatable. IFOF is probably one of the most difficult tracks in my experience to negotiate and navigate. On the dominant hemisphere, you have naming difficulties. I think, and you shouldn't have naming difficulties that deep down, because you're not in the territory of arcuate, you're not in the territory of the cortical surface. So stimulating on the dominant hemisphere, IFOF would give you anomia. On the non-dominant hemisphere, people talk about this non-verbal semantic cognition. So I'll give you an example. People talk about this, and I have tried it. There's a test called pyramid and palm trees. I don't know if you have heard of it. So the pyramid and palm trees test really it binds. It's a semantic binding test. So for example, if I ask you what connects pyramids and palm trees in your mind, and you'll say, oh, that's Egypt. Aha. So that is semantic binding, which is non-verbal. Okay. So your concept of binding two seemingly unrelated nouns into one concept. This is your semantic cognition. And so the non-verbal semantic cognition is thought to be on the non-dominant hemisphere, but I have not perfected it in my own hands. I do not have a huge experience in that. It's, I involve a neuropsychologist for all my awake surgeries, but these tumors are rare, and so I'm still exploring it. Sorry, we can.
Thank you. So we will go right, sir. I think we are running over time, so we will. So Dr. Saqib, can you please ask your question?
Thank you, Dr. Chohan, for this wonderful talk. I am instructor in the section of neurosurgery at Khan Hospital and graduated last year in December. So I have a couple of questions. One is regarding the neurological outcomes. Can you explain if most patients who have slight intraoperative deficits during resection of the tumors, particularly those which are located more towards growing more towards the frontal lobe, and particularly speech-related deficits, do they tend to improve with time? And secondly, do you have psychological assessment of all your patients with insular gliomas preoperatively as well as postoperatively?
Excellent question. So insular gliomas are notorious for postoperative deficits. And if you look at some studies, the postoperative deficits are as high as 40%, which in other cortical gliomas is an unacceptable rate of immediate postoperative complications. Most of those complications are speech related, whether hesitancy, naming difficulties, expressive aphasias, and a vast majority of them, I would say almost all of them, unless you have a stroke on your on the MRI, they will improve in 3 months. So I don't pay too much attention to immediate postoperative deficits. I do look at the DWI sequences on postoperative MRI, which has to be done within the first 48 hours. So if you are, with your own conscience involving or invoking all, functional safety measures, anatomical safety measures, superficial and deep, you should be good. The second question was neuropsychological assessment. I'm a big proponent of that. We have a couple papers coming out. I have a big project going on right now so all of my awake patients, since I started being an attending, all of them have had a detailed neuropsychological testing preoperatively, and then sequentially, depending on if they are undergoing radiation or not, so the time is a little bit off, but up to 1.5 years. And we are going back and analyzing that data. I think your point on the involvement of frontal lobe, which is often considered silent, is very well taken because it's not silent. The orbitofrontal lobe, the dorsolateral prefrontal cortex, the cingulate cortex, I mean, these are not silent in humans. These are the most evolved. The biggest gain that humans have is in the frontal lobe. So it's the right thing to do. The more you look, the more you will find. The more deficits you look for, especially neuropsychological standpoint, the more you will find. And so the deficits that are reported in literature are often your language and motor related deficits. But the tide is turning. I think more people are looking into neuropsych outcomes as well.
Thank you, sir. So can we take one more question, Dr. Akhtar? Dr. Waqas,
yes.
just
Go ahead.
one last question by Dr. Waqas, please. Go ahead.
Yes, thank you so much, Dr. Omar Chohan, for such a nice presentation. I am a final year resident at AKU. So my question is, I totally understand your standpoint on that neuro-oncological outcome is not superior to the functional outcome, and one should always prefer a functional outcome over the oncological outcome. But my question is, in your experience, or what do you think about the future aspects on the posterior superior insular gliomas that you think are the surgical blind spot? What do you think in the recent advancements would help us resect those as well?
I think your functional mapping is very important because, as I said, they're very hard to get to with a Transylvanian approach. You can never open the Sibben fissure that wide. And so if you are employing techniques of careful mapping, often you can find a corridor to get either a transsulcal corridor or a transcortical corridor, avoiding your eloquent areas to get to those. At the end of the day, you know, my permanent line to my patients is that is the following. I tell them that my number one job is not to hurt you, right? So you can never compromise function. And then the number two job is to take the tumor out. So I think that principle is very important. Gone are the days of you know, cowboy surgery. Dr. Inam will tell you.
Thank you. So I would now request Dr. Juma and Dr. Akhtar if they have closing remarks before we end our session.
I just thoroughly enjoyed it, Omar. This was just wonderful. Thank you very much. And you were the inaugurative speaker for the NOWS series. So I just wanted to take this opportunity, Hassan, that the NOWS series, the Neuro-Oncology webinar series, is going to occur every other week. So all those who are here, you know, we will have excellent speakers like Dr. Chohan, and this will happen every other week. So so put it in your schedule. There's a lot to learn. I learned today a lot from Omar, and I'm sure everybody else did. Thank you very much, Omar. Dr. Juma.
Dr. Juma, please.
So, Dr. Chohan, I just want to repeat that. I want to reiterate the thanks. I just do really want to add that one bit because I'm such a Transylvanian person. The Transylvanian route does have huge advantages, and I don't think it should be disregarded upfront. In other words, people should explore what's best for them. And and indeed, the point you make about the difficult corner is in fact one of the safeties features of the transinsular approach, because it Transylvanian approach allows you to keep away from that really dreaded thing, just wandering into the corticospinal tract. So I just basically work upper sulcus, lower sulcus. Those are the three landmarks I look for: upper sulcus, lower sulcus, and the first lenticular stride. And then I work between. I triangulate. This is my triangle, and I work between these sides. So I think that one should have an open mind about this. But I have noticed also that the majority of the work that is being published now is cortical windows. I have noticed that. And so obviously, so, one has to find one's own way.
Absolutely.
Absolutely
Thank you.
correct. I mean, a Trans-Sylvian approach is a beautiful approach. All neurosurgeons should know how to open the Sylvian fissure safely, whether or not you're doing insular gliomas. It's a beautiful technique and a must technique to have. And in no ways I want to disregard that. Absolutely, that's what works for me, sir. So that's all I wanted to say.
Absolutely.
Thank you so much. Thank you so much.
Great.
Thank you, Dr. Juma. Thank you, Dr.
Thank you.
Thank you so much,
for
Dr.
having me.
Omar Chohan. Thank
Thank
you
you,
for
Omar.
accepting our invitation.
right.
Thank you all. See you, inshallah,
And
in 2 weeks.
do
All
get
right,
in
take
touch
care.
when you're in Karachi next. All right.
We'll do, inshallah. Okay. Assalamu alaikum.
All right. Thank you. Thank you all.
All right.
Alaikum assalam.
Thank you all. Lovely session.